My name is Kelly Smeester. I'm a physician assistant at South Denver Gastroenterology. Please use this QR code to register for today's meeting. Today we'll be discussing MASLD and metabolic ALD. We will start with a patient case. This is Ashley, a 52-year-old woman referred for evaluation of abdominal ultrasound showing hepatomegaly and increased hepatic echogenicity consistent with steatosis. She feels well without any complaints. Her medical history is significant for PCOS, hypertension, hyperlipidemia. Physical exam shows smooth, non-tender liver edge. Social history, she averages 2 glasses of wine per day, and medications include amlodipine, atorvastatin, multivitamin, and milk thistle. Her vital signs are listed here. Blood pressure mildly elevated at 140/78. Height and weight are 161 and 5.2. This equates to a BMI of 29.4. Her labs are listed below. She has an elevated AST, ALT, and ALK-Phos. Also, A1C is elevated at 5.9 and triglycerides are 185. Our patient underwent a fibrosis assessment. This is a FibroScan. This provides 2 separate values. The first being a fibrosis score. This is measured in kilopascals, and our patient had a score of 11.4. This places her in the significant fibrosis or F3 stage. It also shows a CAP score or a controlled attenuation parameter, which is a measurement of hepatic steatosis. Her value was 310, which also placed her in the severe steatosis range. This next chart shows steatotic liver disease and shows it as an umbrella term and all the things that fall beneath that. So starting off, we have our metabolic dysfunction associated steatotic liver disease, also known as MASLD. Then we have our metabolic dysfunction associated steatohepatitis, which is a progression. Next, we have our MASLD and increased alcohol intake, also known as MetALD. This is the primary driver of our conversation today. You can see that this has a continuum. It can be either MASLD predominant or ALD predominant, depending on somebody's weekly alcohol consumption. This is listed out both in weekly and average daily amounts for men and women, respectively. You'll note on the average daily amount for women, it's 20 grams per day, and men 30 grams, and up to 50 to 60 grams per day. This equates for women about 1.5 drinks per day at the low end, and for men about 2 drinks per day at the low end, and at the upper end, 3 drinks for women and up to 4 per men per day. Our next category here is our alcohol-associated liver disease, just ALD independent of any metabolic factors. And then we have our specific etiologies. This is our drug-induced liver injury, also known as DILI, our monogenic diseases, such as lysosomal acid lipase deficiency, Wilson's disease, or inborn errors of metabolism. And lastly, we have hepatitis C, which also our miscellaneous category, which includes hepatitis C virus, malnutrition, and celiac disease. And then on the far right, we have our cryptogenic steatotic liver disease, which is of unknown etiology. So as we talk about alcohol and how this may impact liver disease, it's important that we have an understanding of the equivalences between alcoholic beverages. So you can see here that each of these listed are essentially equivalent. So a 12-ounce regular beer is essentially equal to a 5-ounce glass of table wine, which is equal to about a 1.5-ounce shot or distilled spirit. As we just discussed, the parameters are typically listed in grams, and so one beverage here is equal to about 14. So this may be a useful chart to use with our patients to make sure that we all understand we're on the same terms when we're discussing. So this next slide is really important. It helps understand the key pathogenic mechanisms in metabolic ALD. And the previous nomenclature, non-alcoholic fatty liver disease, suggested that there was no alcohol component to this process. However, as you can see here, these NAFLD or metabolic risk factors converge with alcohol intake to produce a similar pathway. So as a reminder, these metabolic risk factors are insulin resistance, diabetes, obesity, unhealthy diet, sedentary lifestyle. And as I said, these can converge with alcohol to produce impaired lipid handling, oxidative and ER stress, causing cellular death. There are other factors here, disruptions to the intestinal microbiome and inflammatory responses that all work together to accelerate fibrosis and disease progression. This slide shows this in a similar way, but kind of gives specific parameters. So you can see on the top left, we have the total transient elastography values corresponding to a fibrosis stage. And then at the bottom left, we have the cardiometabolic factors, the genetic factors in alcohol use. And as someone progresses, they might start out at MASLD, but depending on their alcohol consumption, they might trend towards metabolic ALD. And then if they have severe alcohol consumption, they may land more on the right side with just pure alcoholic liver disease. So the important thing here is to see that it's a spectrum and it really depends on somebody's different risk factors. The risk for decompensation is calculated depending on these different categories. You'll see at the top right, the 5-year risk factor is the highest at 15 to 50%. These are the patients with the highest kilopascal scores, the highest fibrosis stages, and the increased alcohol consumption places them at this highest risk. So because it's important that we understand alcohol consumption can affect our patients, this particular study looked at the use of alcohol with various biomarkers. So 184 patients were analyzed. They had the typical metabolic risk factors and then used a method, a questionnaire. The Audit C is an alcohol use disorders identification test. And then other biomarkers like serum biomarkers, as well as several different things called the urine ethylglucuronide and the hair ethylglucuronide to help kind of quantify their alcohol consumption. So ethylglucuronide is a metabolite of alcohol. It can accurately detect potentially harmful alcohol consumption. So putting this together, they found that moderate to excessive alcohol consumption occurred in about 29% of patients with NAFLD or 25% in MASLD. So the point being, patients who may be previously identified as having just metabolic risk factors, in fact, did have risk for liver injury related to alcohol use. So it's important that we attempt to identify this in our patients. The other important thing here to note is that the different biomarkers were relatively similar to the questionnaire in terms of predicting alcohol consumption. I just want to dial down into exactly what the different factors are for metabolic disease. We can see that the parameters are listed here. BMI greater than 25. This should be adjusted by race and ethnicity. A fasting serum glucose of greater than 100 or being on some sort of treatment for type 2 diabetes. We also have blood pressure greater than 130/85 or on an antihypertensive agent. Triglyceride levels greater than 150 or a lipid lowering agent, or HDL levels less than 40 or on a lipid lowering agent. So these patients, if they have hypertension or hypertriglyceridemia in isolation with no alcohol consumption, we can accurately conclude that they are a MASLD patient. However, in the middle here, we have our assessment of alcohol use. So we need to be sure to ask our patients to how much alcohol they're drinking. The use of that chart I mentioned earlier could be helpful. We can ask about drinking patterns, daily intake, binge drinking, and then any economic or social consequences of their alcohol use or any prior hazardous drinking. And then we should consider getting this PEth. And we'll talk a little bit more about this in a moment, but PEth stands for phosphatidylethanol. It's a serum biomarker that can help estimate how much alcohol someone is drinking. So if a patient has undisclosed or uncertain quantity of alcohol intake, we can certainly run a PEth on them, and this can help give us really helpful biomarker to give us a quantification. So if their PEth falls between 25 and 200, they're more likely a metabolic ALD patient, versus if it's greater than 200, they fall in that alcohol-associated liver disease category. And then on the far right, again, we want to exclude any differential diagnosis that could be contributing to their liver disease. So for our patient, we did conduct a PEth. Her score was 120, which fell in that category between 20 to 200, moderate to heavy alcohol consumption. So let's talk again a little bit more about what the PEth is. This is the phosphatidyl ethanol. It is a serum biomarker, and it's detectable for 3 to 12 days after one single binge. And its half-life is about 3 days. So this is a very helpful marker because, as you can see in this chart here, the blood alcohol content peaks after about 2 hours and then goes back to baseline by about 8 hours. But the PEth remains elevated. So it's very helpful to help measure and quantify how much someone is drinking. It's been likened to the A1C. It's obviously a different measurement, but similar idea, where it provides a more long-lasting kind of idea of somebody's consumption versus just a point in time. And this also shows that there's no significant variability by sex and BMI, making it a very reliable marker to use. So here's another study. This is conducted in patients that were overweight or obese. And because we know metabolic ALD may increase liver fibrosis progression, this study aimed to assess the performance of non-invasive testing for detecting significant fibrosis. So it started off with 659 patients, 42 were excluded for the reasons listed below, and then 617 were enrolled in the study. Some were excluded because they had missing data or they were never drinkers. Others did not meet the alcohol consumption criteria. But they finally broke it down into females and males and got to, and these patients had PEths greater than 25 to qualify at this point. And 97 were analyzed with suspected MetALD. And the point here being that 15.7% of the patients of the original 617 that were analyzed did have the risk of metabolic ALD. So it's very important that we don't ignore how alcohol may be affecting our patients, that we use that in addition to the metabolic risk factors, and making sure that this is something that's part of our assessment so that we can address it with our patients. So back to our patient case. So Ashley also had a medical history of PCOS, hypertension, and hyperlipidemia. We're going to spend a few moments talking about how alcohol and hypertension are affected. This was a meta-analysis with 32 randomized controlled trials involving nearly 800 patients. They found that alcohol has a biphasic effect on blood pressure. It decreases blood pressures up to 12 hours after consumption. And then beyond that, at 13 hours and beyond, blood pressure can increase. So it's important to know that when we are checking up blood pressure in our patients, whether or not they've had recent consumption of alcohol, that may skew their findings. And as we're trying to decide if someone fits the metabolic criteria, this is important to understand. This is a similar finding with hypertriglyceridemia as well. Interestingly, those patients that had a known history of hypertriglyceridemia only had a 3% of increase in their triglycerides after alcohol consumption, whereas patients who had non-hypertriglyceridemia at baseline had a significant increase, as you can see on the right, up to 53% and peaking at that 6-hour mark. So again, the timing of checking our labs in our patients is impacted on when they have consumed. So for Ashley, as we put it all together, looking at her labs, her medications, her alcohol history, her lab findings, transient elastography scores, we can conclude that she has metabolic ALD with MASLD prevalence. So we have questions to answer here. What are the current treatments? Starting off, we always want to discuss diet. The Mediterranean diet is recommended. We want to address exercise, weight loss. These are the cornerstones of management for these patients. We also can consider, is she a candidate for resmetirom or possibly a GLP-1? What are our recommendations regarding alcohol use? even though she was in that moderate category and only drinking 2 glasses of wine a night, she still should stop drinking alcohol, as it is certainly a factor contributing to her liver disease. And does she need hepatocellular carcinoma screening? The answer is yes. She does have that severe fibrosis, and so we want to make sure we are checking this fertility. As we think about the metabolic ALD definition for clinical trials, we want to base it on objective biomarkers. We want to overcome underreporting of alcohol use. We want to standardize the assessment of recent alcohol use and verify alcohol abstinence in those patients who say they are no longer drinking. This is, again, the PEth is a great biomarker to do that. We also want to ensure that the drivers of liver disease are present. So if we're diagnosing someone with metabolic ALD, we need to verify that they have those cardiometabolic risk factors and that they have persistence of the hypertension or their hyperlipidemia after they've stopped that alcohol use. As we just discussed, the timing of those lab values can be dependent on when they've last consumed alcohol. And lastly, we need to consider exposure to risk factors in the fulfillment of this criteria during the last 6 to 12 months. So take-home messages for today. We have this new definition of metabolic ALD. This is alcohol intake beyond 140 to 350 grams for women, or 210 to 420 grams per week. This equates again to about 10 to 25 drinks per week for women and 15 to 30 drinks per week. This clinical criteria could underestimate metabolic ALD or also alcoholic liver disease. So using the PEth alcoholic biomarker can really help us quantify and understand someone's consumption level. We want to make sure that the drivers of liver disease are present and reassess metabolic dysfunction over time. And make sure they have this adequate exposure to the risk factors that it's present for that 6 to 12 month length of time. And lastly, criteria for clinical research should facilitate objective metabolic ALD diagnoses. So we want to make sure we can then compare groups across socio and cultural realities. And that concludes today's talk. If you would like to visit the GHAPP MASLD MASH Community Network for additional disease state education and Resdifra webcasts, you can scan this QR code. And we appreciate your feedback. Please scan this QR code to complete a short survey and share any thoughts you have with us. I'm happy to take any questions and answers.